My name is Gorav Datta and I'm a consultant orthopaedic surgeon in the south of England. Today, in this educational production, we will focus on clinical examination of the knee joint as well as demonstrating how to aspirate and inject the knee. Clinical examination of the knee follows Apley's system of look, feel and move, followed by specialised tests. So before we have the patient lying supine on the couch, standing the patient up and observing them walking is a good starting point. Examining the patient from the front, standing, one can see any evidence of deformity, for example varus or valgus deformity, any evidence of swelling and any scars. One then comes to the side of the patient looking for any abnormalities from the side, and here one would see flexion deformities or any evidence of recuvatum. And then finally, inspecting from the rear, one can look for any evidence of masses or scars in the popliteal fossa. Once one's inspected for any deformities, one can then look at the patient's gait, looking for evidence of a varus thrust or an antalgic gait. An antalgic gait is where the patient will spend less time on the affected side due to pain. Following inspection, we feel, and a starting point is to palpate the tibial tuberosity in order to measure the circumference of both the thigh and the calf musculature. So palpating the tibial tuberosity, one can mark it with a marker pen and also do it on the normal side as well. After this, we take a fixed point above and below the tibial tuberosity. One can measure 20 centimetres above the level of the tuberosity for the thigh, and then a fixed point below the level of the tibial tuberosity to measure the calf musculature, in this case 10 centimetres. One can then take accurate measurements and compare both sides with each other. So on the affected side, firstly, we measure the thigh musculature, followed by the calf musculature. And these give relatively accurate measurements of musculature. Following measurement of musculature, one then looks for an effusion and feels for an effusion. There are a number of ways to do this. Squeezing the fluid out from the suprapatellar pouch and then seeing there's a positive patellar tap. For smaller effusions, again, a bulge test where you slide fluid from the suprapatellar pouch and then just slide your thumb over the lateral side, and a positive test will be seeing a bulge on the medial side. Once we've assessed for effusion, we then palpate the bony landmarks around the knee joint, and this is best done at approximately 80 to 90 degrees. And a useful starting point is the tibial tuberosity. So palpate the tibial tuberosity, work medially, palpating the pes ansorinus, which is the insertion of the hamstring tendons. A bursitis here may cause tenderness on palpation. Then come back to the tibial tuberosity, again watching the patient's face at all times, and then palpate along the line of the patellar tendon, again looking for any tenderness, watching the patient's face at all times. A tender patellar tendon may indicate tendinitis. And go to the inferior pole of the patella. Then come with your fingers back down again to the joint line, feeling the lateral joint line. This may be tender either in a meniscal tear or osteoarthritis. And then palpate the medial joint line, again watching the patient's face. This can be tender in either osteoarthritis or a chondral lesion. Following palpation, we examine range of movement. A useful way to start is to stand at the end of the bed, lifting the heels off the bed, looking at passive extension, and also seeing if there's any evidence of recuvatum. One can then ask the patient to imagine he's pushing his kneecaps into the bed, looking at active extension and quadriceps contraction. Just relax now. We then examine flexion, asking the patient to bend his leg with active range of movement. If there's limitation, one can look at passive range of movement, always examining the patient's face to make sure that one's not causing any pain. And then compare it with the other side. Again, bend your leg as much as you can, and then if there's limitation, one can examine passive range of movement by taking the leg a bit further, making sure there's no pain being caused to the patient, and record those details. To administer an injection of Durolane, one must prepare an injection tray. To comprise the injection tray, this must include some sterile gloves, some skin prep, in this case chloroprep, some local anaesthetic to be administered via a separate syringe using a 25 gauge orange needle to raise a bleb of anaesthetic, followed by the depot injection of Durolane to be administered with a 21 gauge green needle, and finally some dressing gauze and a wound dressing. In order to inject the knee, one must first be familiar with the surface anatomy of the knee. This ensures the needle is inserted in the correct position into the knee joint and causes minimum discomfort to the patient. So I mark the tibial tuberosity as a starting point. I then palpate the patella. And then mark the patella tendon. Finally, mark the lateral edge of the femoral condyle. So the needle placement is the infrapatellar area. So we're aiming to put the needle in the space between the lateral edge of the femoral condyle and the infrapatellar area. Okay, so before injecting, we prep the skin with ChloraPrep containing chlorhexidine solution. One then administers the local anaesthetic into the skin and subcutaneous tissues to ensure maximum pain relief. All one does is insert an orange needle, which is a 25 gauge needle, insert it beneath the skin and just raise a bleb. And a couple of millilitres is usually enough. Give it about a minute or so to take effect, and then the patient has complete anaesthesia in that area. Once anaesthesia has been achieved, one then inserts the needle into the retropatellar area and draws and aspirates the fluid. Remember never to bury the hilt of the needle into the skin in case the patient suddenly moves. If that happens, then the needle may break off and actually be lost inside the knee joint. Then, once one has aspirated enough fluid, with the needle still in the joint, exchanging syringes, injecting the Durolane, slowly injecting. And again, not burying the needle too far in case the patient were to suddenly move, the needle may break off. And then finally, some gauze and remove the needle with some gentle pressure over the wound. Following inspection, palpation and assessing range of movement, we then perform the specialised tests that are applicable to the knee joint. Now, there are a number of specialised tests that can be performed. For the purposes of this examination, we're going to focus on the key ones that a general practitioner may use to identify the major problems. Specialised investigations and tests can be broadly divided into assessments of meniscal pathology, abnormalities of the ligaments, and abnormalities of the patellofemoral joint. Firstly, one assesses the collaterals, taking the leg, supporting it in the elbow joint, in full extension of the knee, taking all the way to the leg, producing a valgus strain, again watching the patient. This tests the medial collateral ligament, and then a varus strain, testing the lateral collateral ligament. This is performed at 0 degrees and then repeated at 30 degrees of flexion. A valgus strain for the medial collateral and a varus strain for the lateral collateral. The significance of performing it at 0 degrees is that if there is opening at 0 degrees, then that implies that the posterior structures may also have been affected. Anterior and posterior cruciate ligaments, one can perform Lachman's test. This takes the knee at about 25 degrees, one hand on the femur, the other hand on the tibia, and gently applies a PA-AP force through the kneecap, looking for instability of the posterior cruciate ligament and the anterior cruciate ligament. One then bends the knee to 90 degrees, stabilises the foot, and a gentle AP-PA draw. Again, looking for a firm endpoint or any signs of instability. At 90 degrees, one can also place a piece of paper along the line of the tibia to see if there's any posterior sag. Finally, for patellofemoral joint pathology, a useful starting point is performing Clark's test. So with one hand on the kneecap, not pressing too hard, we ask the patient to push his kneecap into the bed. This causes an active quadriceps contraction, and if positive, will cause pain. This can be positive in osteoarthritis or chondromalacia patellae. We then look at the apprehension test for patellofemoral joint instability. This is done by carefully watching the patient and providing a lateral stress on the patella, looking to sublux or dislocate it. A positive test sees the patient forcibly contract his quadriceps with discomfort as he feels that the patella may dislocate. Finally, we assess patellofemoral tracking with the patient sitting on the side of the bed. Can you sit on the side of the bed? With the finger and thumb on either side of the patella, the patient extends his knee and flexes again. And here we're looking for if there's any lateral drift of the patella and making sure the patella slides in the trochlear groove. And again, compare it with the other side and bend it again.